Pregnancy changes the nutrient requirements of a woman, in particular the needs of specific micronutrients increase to a large extent. It is important for a woman to meet these increased requirements to support a healthy pregnancy and the development of the child long term. Research in recent years has shown that nutrition and other environmental cues that act during this specific and sensitive period of developmental plasticity induce lasting changes on the physiology of the offspring and its long-term health and disease risk up to adulthood and old age. Some key factors that are particularly important is the body weight of the mother at the beginning of pregnancy, the change of body weight during pregnancy, which we also call gestational weight gain, the occurrence of diabetes in pregnancy, and of course, dietary and lifestyle choices. In this unit, we will explore the physiological and metabolic adaptations that occur during pregnancy. And based on these considerations, we will look at the changes of nutritional requirements during the different stages of pregnancy. In the course of a normal pregnancy, profound changes in anatomy, physiology, and metabolism occur already soon after fertilization, and they continue throughout the whole course of pregnancy. Physiological and anatomic changes can be observed in almost every organ system in the maternal body. Recognizing these changes is crucial in differentiating between normal and pathological pregnancy.
Many of the physiological adaptations that occur during pregnancy are driven by hormonal changes. Initially, they result from modulations of the corpus luteum, and in later pregnancy, from fetoplacental and maternal endocrine glands. Elevated levels of luteinizing hormone, human growth hormone, human placental lactogen, estrogen, and progesterone can be observed. The uterus expands and increases remarkably in size and weight. Its volume can increase 500 to 1,000 times greater in pregnant women to that of non-pregnant women. Its weight increases from around 70 grams to 1,100 grams at term. This extensive growth is mainly due to hypertrophy and stretching of myometrial cells and smooth muscle cells of the uterus, but is less dependent on new myocyte proliferation. The breasts enlarge in size and volume after the second month. Breast tenderness can already be observed in the very beginning of pregnancy and is often one of the first signs a woman notices. Alterations of the cardiovascular system manifest as early as the 4th or 5th week of gestation and peak during the 2nd or early 3rd trimester. They're driven by hormones, changes in other organ systems, and mechanical forces. Pregnant women are in a state of hypervolemia as blood volume increases by 45 to 50%. This results from an increase in both blood plasma and erythrocytes to ensure elevated blood flow to uterus and placenta in order to provide nutrition and oxygen to fetus. Plasma volume increases by a greater amount than blood cells, heightening the risk of physiological anemia. Higher plasma volume to blood cells ratio reduces blood viscosity, which supports placental transfer and results in decreased cardiac work. Cardiac output, the product of heart rate and stroke volume, represents one of the most significant physiological changes. Its increase is associated with an increase in venous return and greater right ventricular output. In early pregnancy, the increased cardiac output is mainly driven by a rapid rise in stroke volume. This peaks at 16 to 24 weeks and returns to pre-pregnancy values by term. Advancing pregnancy is associated with an increasing heart rate. By the end of pregnancy, this is the determining factor for increased cardiac output as stroke volume decreases. Despite the increases of blood volume and cardiac output, blood pressure decreases slightly due to decreased vascular resistance. Changes in the respiratory tract are mainly driven by progesterone in early pregnancy. Even before, mechanical changes due to a rise in diaphragm occur in the later stages of pregnancy. The result of occurring adaptations is an increase of the volume for gas exchange and an enhancement in oxygen availability while exhaling as much carbon dioxide as possible in one breath. Progesterone is a respiratory stimulant. It is thought to increase sensitivity to carbon dioxide and to lower its threshold in the respiratory center. It may also relax the smooth muscle of the bronchioles and decrease airway resistance up to 50%, resulting in reduced work of breathing and enhanced airflow. The volume of the lung progressively increases from the second trimester onwards, leading to a 30 to 40% increase of the tidal volume. The increase in volume is a result of the rise in diaphragm and alters the center of gravity to be shifted forward, leading to problems with balance. Lumbar lordosis is an adaptation to shift the center of gravity back, joints becoming laxer in order to accommodate delivery. It can, however, increase the risk of injuries such as strains or sprain in the pelvic floor. Intra-abdominal pressure, as well as the mechanical strain during delivery, can lead to denervation or injury, possibly causing urinary incontinence. Also, the gait undergoes alterations, driven by relaxin and progesterone, which affect the cartilage and connective tissue of the sacroiliac joints and the symphysis pubis. Together with an external rotation of the femur, this manifests in increased joint mobility and waddling gait. Metabolic changes ensure adequate nutrient supply to the fetus, which is vital for intrauterine growth and development, as well as building stores for afterbirth. For the mother, they are crucial to meet the increased physiological demands on pregnancy and the postpartum period. The basal metabolic rate increases. Its range depends on pre-pregnancy nutritional status and fetal growth and is highly variable between women. However, when preconceptional nutritional status is very poor, energy intake cannot be increased and physical activity remains the same. There may even be a reduction of basal metabolic rate to sustain pregnancy. In summary, physiological adaptations of pregnancy affect almost all organ systems as well as the psychological state of pregnant women. They support metabolic demands on pregnancy while sustaining normal maternal physiological processes. Moreover, they ensure an adequate supply of energy and nutrition to the fetus for optimal growth and development. While some alteration might manifest very early in pregnancy, others may not present until the last trimester. The changes can largely be attributed to hormonal changes and mechanical forces. When these causal factors revert to the normal state, the adaptations that occur will change back to the preconception state.
This video follows on from the previously covered content on physiological adaptations of pregnancy. It focuses on the metabolic changes that occur. If we understand these adaptations, we are better able to understand the changing nutritional requirements that are necessary for optimal maternal and fetal health. Metabolic adaptations involve coordinated changes of carbohydrate and lipid metabolism that preserve maternal homeostasis and allow timely transfer of nutrients to the fetus in order to optimally support growth and development. In the first half of pregnancy, the physiological adaptations of maternal metabolism prepare the body for the high demands of rapid fetal growth, which occur then in the second half of pregnancy. Therefore, we will begin By looking at changes in carbohydrate and lipid metabolism that take place in early pregnancy, and then discuss how these metabolic pathways differ from changes occurring in later pregnancy. In early pregnancy, insulin-secreting pancreatic beta cells become hyperplastic, resulting in increased insulin secretion. Insulin sensitivity is enhanced, and the nutrient-stimulated insulin response to oral glucose increases. At the same time, glucose tolerance is either normal or slightly improved, with peripheral sensitivity to insulin or hepatic basal glucose production remaining the same. Fasting plasma glucose levels are slightly reduced, with only small changes in insulin levels during the first trimester of pregnancy. Hence, the risk of hypoglycemia is increased in some women during this early stage of pregnancy. Changes in lipid metabolism are analogous to the alterations in carbohydrate metabolism. During the first and second trimester, increased estrogen, progesterone, and insulin concentrations favor lipid deposition, and they inhibit lipolysis, which results in an accumulation of maternal fat stores. This accumulation peaks between 10 and 13 weeks of gestation before the fetal demands for energy to support extensive growth in the last trimester increase significantly. The maternal energy requirements are thus mainly met by increased efficiency of glucose metabolism. Being in an anabolic state, excess glucose as well as dietary triglycerides are stored as adipose tissue. This maternal metabolic pattern changes during the second half of pregnancy. Since glucose is the preferred fuel to the fetus, a modest insulin resistant state develops. This leads to a mild elevation of maternal plasma glucose concentrations to facilitate diffusion across the placenta. Despite increasing basal and postprandial plasma insulin levels, the postprandial glucose concentrations are significantly elevated and the glucose peak is prolonged. The maternal insulin resistance begins to develop in the second trimester and it peaks in the third trimester. It is generated by the release of placental diabetogenic hormones, such as human placental lactogen, growth hormone, corticotropin-releasing hormone, human chorionic somatomamotropin, and progesterone. In late pregnancy, maternal metabolism shifts from an anabolic to a catabolic state, and it promotes the use of lipids as a maternal energy source while preserving glucose and amino acids for the fetus. This shift allows pregnant women to minimize protein catabolism and to preserve glucose as the main fuel for the fetus. Decreasing lipid uptake into adipose tissue through physiologically relative insulin resistance, reduced lipoprotein lipase, and increased lipolysis and mobilization of lipid stores results in a constant increase in triacylglycerols, non-esterified fatty acids, cholesterol, phospholipase, and lipoprotein concentrations in blood plasma until delivery. Adapting carbohydrate and lipid metabolism to the different stages of pregnancy ensures that the increased energy and nutrient requirements of the mother are met while providing the required nutrients for the fetus to ensure optimal growth and development. The previously explained adaptations involve fat deposition in the mother, usually around the breast and the buttock. These storages are beneficial to support maternal homeostasis and fetal growth during the third trimester, and they are also valuable as an energy resource during the ensuing period of lactation. However, excess depositions of fat may have adverse consequences for maternal and fetal health, which go beyond the pregnancy period, as explained by Professor Lucilla Poston, who is an expert in the field of maternal obesity.
A Obesity is a problem for women even before they become pregnant. It's a problem in pregnancy, and actually it's a problem after pregnancy, because if they're thinking of becoming pregnant again and they put on weight, then that's a problem too. So if you're to say which is the best time to intervene, I don't think there is one. What we really need to do is think about intervening before people become pregnant, if they are obese, to try and make them thinner, during pregnancy to try and improve the outcome, and then after pregnancy to try and limit weight gain and weight retention. And if we get that overarching theme of intervention, we're likely to win.
Now that you have an idea on the physiological and metabolic changes that occur during pregnancy, let's look on how that translates into altered nutritional requirements.